Hello, and thank you for joining this OncLive peer exchange titled Expert Perspectives on the Treatment of Melanoma. We have made enormous strides in developing novel therapies for advanced melanoma, particularly in the field of immuno-oncology, where melanoma has been at the forefront of paradigm-defining progress. We continue to see new advances at an accelerated pace as we learn more about the disease itself and how to treat it. Today, I'm joined by a group of international experts in the field of melanoma research. Together, we will discuss the studies presented at the 2019 ASCO annual meeting and will provide you with perspective on how the data relate to clinical practice. I am Dr. Sanjeev Agarwala, Professor of Medicine at Temple University School of Medicine and Chief of Oncology and Hematology at St. Luke's Hospital and Health Network in Bethlehem, Pennsylvania. Participating today on our distinguished panel are Dr. Alexander Egermont, Director General and Professor of Oncology at Gustave Roussy in Villejuif, Paris, France, Dr. Caroline Robet, Professor of Dermatology and Chairman of the Dermatology Unit, also at the same Gustave Roussy, and Dr. Do Schaddendorf, Director of the Department of Dermatology and the West German Cancer Center at the University Hospital Essen in Essen, Germany. Thank you so much for joining us. Let us begin. So a lot of data that's come out at ASCO recently, and let's start with the perioperative approaches to melanoma, and starting with something different, neoadjuvant therapy. And Dr. Egermont, I'm going to start with you. Is there currently a regulatory path forward for neoadjuvant therapy? Nothing yet approved in that setting. Is there a path forward, thinking about both neoadjuvant immunotherapy and for BRAF positive patients, targeted therapies?
Well, I think there will be a regulatory pathway that needs to be developed because we're dealing now with new endpoints, which are kind of testy in the sense that FDA or whatever regulatory agency you're discussing with, they are not used to transforming non-resectable, which is always relatively loosely defined, tumors or lymph node, regional lymph node packages into resectable tumors, and whether that is really a reliable endpoint. Then what is going to be your primary endpoint in that setting? Is it going to be the outcome of surgery? Is it the outcome of pathology? Is it going to be simply relapse rate after all this?
Or survival? I mean, it's a challenge.
And in the end, you will need to show that you have benefit on both sides of the equation, I think. So it will be a pathway that will be developed because it's going to be perhaps the revolution the next 3 to 5 years before us, not just in melanoma, but in multiple tumors.
So having said that, in terms of some of the data that's come out, I'd like you to comment perhaps on the ASCO abstract, the pooled analysis of the neoadjuvant melanoma consortium. And then, of course, there's some data, other meetings of neoadjuvant pembro, nivo-ipi combo, and also neoadjuvant BRAF-MEK.
Yeah, so for the neoadjuvant situation, when you look at bulky or palpable nodal disease, you can look at BRAF-MEK combos and you get the immediate response, and you get a good response rate, which is up and above the 70-75% in that setting, but it's limited to BRAF mutant melanomas. And the trial experience thus far published shows that the impact on relapse-free survival is actually much less than anticipated when you initially look at the response rates and the fact that it may facilitate surgery. What I think is the untouchable data set right now is the combination of anti-PD-1 plus low-dose ipilimumab. There is actually no data in advanced disease that can almost not even stand in the shadow of that data when you look at 3-year, 4-year, 5-year survival rates. But the fact that it gives very rapid and very impressive responses and up to 70% pathologic complete response rates in melanoma patients with palpable nodal disease, where you can also then see in the Amsterdam experience that there hasn't been a single patient who has relapsed so far after just 2 cycles of the combination of anti-PD-1 plus low-dose CTLA-4. So whether the PD-1 is anti-PD-1 is nivo or pembro doesn't matter. And when you give low-dose IPI, all patients go to surgery, nobody fails surgery, and the 70% pathologic complete response rate means
pathological CR rate
this is the new pathway for an approval that will harvest also on the relapse-free survival equation. So I think that's going to be extremely important.